Hi everyone that's just joining. We'll just give you everybody another minute just to join and then we'll start. No one wants to be too late because I think we've all got a football match to go and watch later. Unless you're from Scotland or Wales or Northern Ireland, in which case, if you're from Scotland, you've got a football game to watch on another day. Lovely. People are steadily coming in. Welcome everyone. We're really pleased you're here.
Hello, good evening.
Hi, evening.
Good evening.
Good evening, Victor.
Thank you.
Alrighty, shall we make a start? Welcome to everyone that's here. We're really pleased that you're here. My name's Jane. I am the one of the North Agile reps. So if you are from the North, I'm one of the people that sends you emails. Emmeline, my colleague, is going to tail end, but she's giving you a little wave. She's going to be doing the questions at the end. And we're just really pleased that you guys could be here for this education event. We try as what am I thinking of? Like locations to do an education event once a year. So this one's kind of hosted by the North with Vicky, who is from the North. So welcome. Vicky, if you want to move the slide on. So obviously, hopefully most of you here are members of Agile, but if you're not and you paid to be a part, then please do join us. It doesn't cost very much. I think it's £25 a year. And we run various webinars throughout the year and also try to share information and research opportunities and all of that. So do join us if you can. If you move on, Vicky, for me. Oh, suppose on that one as well. We are on Instagram, we're on Twitter, we're on LinkedIn. So come and follow us on there as well because we do share opportunities on there. And that might be the most easy way to kind of keep in touch with what we're doing on there. Vicky, if you move us on a sec. Great. So just some housekeeping for tonight. So if you can make sure that you do keep your microphone on mute for us. As you've seen, we are recording the session. So you will be able to watch the recording at some point on our YouTube channel, but it'd be great if you can stick around to the end because we're really keen to get everybody's questions and feedback and things like that. If you do have any questions during the session, I don't think Vicky will be able to see kind of hands up or anything. So if you pop your questions into the chat, then Emmeline will kind of try and come to those at the end and we'll try and get all your questions answered. If you keep your phones on silent and things like that, that's great. So it doesn't distract anyone. If you need a drink, we're here for the next hour. So go and grab a drink before we start. And then if you do need any help, Heather is monitoring the Agile email page. So if you do need any help, if you're struggling with your sound or your vision or anything, give her an email on that email address and she will try her best to help you with that and get you on to us tonight. If you want to just move on for us, Vicky. So just before Vicky starts, I just wanted to let you know that there are a few vacancies on our wonderful committee. I would highly recommend it. It's a great group of like-minded people getting together to kind of share knowledge and try and make physiotherapy with older people the best it possibly can be. We're looking for a comms officer. Now, there are comms officers, it's just an extra person, so you wouldn't be the only person there. Just to kind of help out with some of the comms work because we do try our hardest to try and get stuff out to you guys. If you are from Northern Ireland, we're looking for a Northern Ireland representative and we are also looking for a Scotland representative. And as a North representative, I can highly recommend being part of the national committee. So do, if you're interested, come and let us know. I'm more than happy to chat to anyone about any of them, as is the rest of the committee. And they're all really, really lovely people. So do email us if you are interested. So I'm going to pass you on to Vicky. So Vicky is a mental health physio in Liverpool. She is a professional doctoral student in health and social care at the University of Derby, and she's currently co-developing falls guidelines for staff who work with inpatients with mood disorders. And she's going to take us through kind of some of her doctoral work tonight. So over to you, Vicky.
Hi everyone, this is my debut work in progress show. So today I'm going to cover about mood disorders and falls, mood disorders and osteoporosis, falls, mood disorders and physiotherapy, which is some previous research I did as part of my professional doctorate, and also about the co-development of the falls guidance. So yeah. So start with a bit about what mood disorders are. So depression, that's low mood, tiredness. And you can also have sleep issues. So you might have poor sleep, lots of sleep or poor quality sleep. It does vary. You might have a lack of interest in things that you were previously interested in. With depression, there may or may not be a trigger, a cause. So sometimes like grief can be a cause or something, but sometimes you don't know quite what caused it. There is an increased risk with family history, so that's partly genetics, but also sort of can be like the environment and things. And there's also psychotic depression where you get delusions and hallucinations. And I'll mention a bit more about delusions and hallucinations when I get to the manic bit. So bipolar disorder. So you've got the high moods, so the mania or hypermania, which is just a bit below manic, and you've also often got the depression, but you can also have mixed moods, so where you feel both high and low, so you're energized but upset or sort of anxious and edgy and things. But also a lot of the time with bipolar, the mood's stable. They're not always sort of high or low or mixed. It is a lot of the time just stable and okay. Bipolar 1 is there's been at least one manic episode lasting at least a week, and there may or may not have been depression as well. And bipolar 2, there's at least one episode of depression and hypomania that lasted at least 4 days. There's also cyclothymia, which is sort of a bit below bipolar. So that's you've had episodes of depression, low mood, and sort of the hypomania over 2 years, but it's not enough to be diagnosed with bipolar. And there's also the rapid cycling bipolar, where you can have lots of variable mood. So the depression, the mania, the mixed, yes, lots within 12 months. And like all the mood disorders, genetic, psychological, social, and hormonal factors can all have an impact on them. So mania. So this is sort of part of bipolar. So it's the elevated mood that lasts at least a week. And you've got the high energy and you're very excited and enthusiastic and you sort of feel wired. And it's sort of very excitable and you've got racing thoughts, talking fast. You can have minimal sleep and feel fine. And it's the overconfident and risky behaviour, which of course that can be then the falls risk. You might be psychotic as well, having delusions and hallucinations. It might be euphoric and very happy, or you might be dysphoric with your mania and just having anger, irritability, restlessness. It is variable. And yeah, schizoaffective disorders. I'm not actually including schizoaffective in my research, but I am mentioning it here to sort of, because it is involved mood issues. So it's schizophrenia and the mood symptoms. So with the schizophrenia, you've got the hallucinations and the delusions. And the hallucinations can be, in any of the 5 main senses. So the touch, vision, taste, hearing, all those ones, you can have the hallucinations. And it's important to remember that people might not be distressed by the hallucination. So yes, I've had some people who've hallucinated jungle animals and found that very distressing. But appropriate for this evening, I did also once have a patient who used to hallucinate football matches, and he liked football, so he found that was quite fun. And also, the other thing to remember with hallucinations is the patients might not be telling you about the hallucinations because we can all see that cat. So why do we need to talk about the cat? And sometimes you do just need to sort of prompt people about hallucinations. And with delusions, it's believing things that aren't real or true. And you can also have like the disorganized thinking and speech. And so schizoaffective disorder, it might be like the depressive type or the bipolar type with the manic side as well. So the treatments for people with mood disorders, I think the most important thing is the patient preference and sort of what they want and are willing to engage with. And that's something that I think sometimes gets forgotten about, how the patient is part of evidence-based practice and their thoughts and views. Exercise, which I'm going to go into a bit more detail on the next slide. If you can identify cause of what's happened, then treat that. I know someone who had bipolar manic issues because of hormonal issues and needed sort of treatment with that. And if it's like grief, then bereavement counselling or something can help. And so yeah, it's managing the cause. And then also that links in with like the identifying triggers, because sometimes with bipolar people, sort of, it might be like a holiday or something can trigger, and it's sort of knowing what the triggers are and how to manage them. And it might be that working with like friends and family or health professionals to sort of have plans of, well, yes, when I go on holiday, I do get sort of more stressed, so I need sort of to pay extra for the better seats on the airplane or whatever. Yeah, so lifestyle changes of the reducing alcohol, not smoking, healthy diet, which I think is probably good advice for all health conditions. Talking therapies, there are a range of talking therapies, but of course, the most important thing is that the patient gets on with the therapist. And that is the key thing with whether any of the talking therapies will work. The actual talking therapy type is less of a factor than the relationship between the therapist and the patient. Support groups, there are some support groups for people with mood disorders and things. And sometimes we still do ECT, which I've had mixed results from that with patients I've seen who've had that. There's also lots of nice medications that can help with mood disorders and things. I'm not just going to read them out because then that would just be me reading, but there are medications that can help, and the medics should be involved with that and things. And yes. So exercise. So as we are physios, it's probably useful that we are aware of benefits and do exercise and things. So for mood disorders, it's recommended by both the World Health Organization and the NICE guidelines. And effective interventions for mood disorders, particularly intensely, is sort of like walking, jogging, yoga, and strength training. And sort of the benefits of exercise is, affecting the neurotransmitters and sort of helping, there's physical and psychological benefits, because it's that behavioral benefit of sort of feeling, well, I can do this, and helping your self-regulation and self-efficacy. There's lots of research about exercise and mood disorders, so yeah, it is good for us to do that. Misdiagnosis. Yeah, I wanted to include this because I think it happens both ways, as I show on this slide, that you can get mood disorders misdiagnosed with other mental health conditions such as schizophrenia, which evidently is more common in Black people, that they get misdiagnosed. And bipolar, that can just be diagnosed as depression if people haven't fully realised the hypermania episodes. And there is research saying that depression and bipolar may be underdiagnosed. But also, I think it can happen the other way with like mood, autism and like ADHD sometimes being misdiagnosed as mood disorders just because of the way those people are presenting, which of course then isn't helpful because they're perhaps given medication or something. And yeah. So, falls and mental health. So, for working age mental health service users, so those like 18 to 65 or 70, there's a 4 times incidence of them having a hospitalised fall compared to the general population. Dementia, that increases falls risk because you've got like the impaired judgment and ability to recognise and avoid hazards and visual spatial perception changes, and sort of the gait and balance changes is variable because I mean vascular dementia, if they've had a stroke or something and it's affected the balance area, then they're more likely to have getting balance changes, and particularly the Parkinson's symptoms with like Lewy body dementia and dementia with Parkinson's, they're going to have issues. And schizophrenia, psychosis, you've got they've got increased falls risk because of the altered insights and awareness due to the delusions and hallucinations. And so like they may fall trying to step over something that isn't there. And also it's possible that they're less active and they've got poor diet. And also medication side effects, because you can get Parkinsonism from some of the medications, which is basically affecting the basal ganglia as it does in Parkinson's. So you can get, it looks like you've got Parkinson's, but it's just from the medication. Anxiety, that increases risk of falls as well. And people who fall are also more likely to be anxious. And so, so falls and mood disorders specifically. So having depression, that increases your falls risks by 4 times. And both untreated and treated depression increases falls risk. And there's no single reason to explain this, but it's probably due to like the altered motivation levels and activity levels. So if you're depressed, you're not really that bothered about doing things, and you're just sort of probably going to just like stay in bed or just sort of sit on the sofa or something. And so of course that deconditions you and that gets you weaker. And so that's with the activity levels of you just getting deconditioned. But equally, if you're manic, then you're very active and there's a risk that you're going to fall over because you're sort of too alert. I had one patient who he had, I think, Friedreich's ataxia, and the stage he was at, he should not have been able to walk physically, but because of his manicness, he thought he could still walk and would try and walk and fall over. The gait changes that you can get, so sort of that's perhaps with like the deconditioning or perhaps with the medication side effects, you can have gait changes. Or perhaps if you're sort of related and you're trying to run, that can happen. Changes to sleeping patterns, so just that you might be sleeping more or poor quality if you're depressed, and sort of not really trying to sleep but not really feeling rested, so you sort of feel tired and then more likely to fall. Or if you're sort of manic and elated, you might be sort of not having much sleep at all and then falling to that. The medications, like I said, some of the side effects from the medications can cause Parkinsonism and stuff. And there's the extrapyramidal side effects that can cause issues. And I think, we need to be aware of if people are on sort of like psychotropic medication and their gait does suddenly change, is it because of the medication, and do they need, medical review and medication review? ECT, that has been found to be a falls risk, and sort of, you are getting general anaesthetic when you have that, and it is sort of doing something to your brain. So, there are a couple of studies that have, confirmed that's a falls risk. There's been less falls research into bipolar. Stewart et al. Was a case control study, and they found there is an increased falls risk in bipolar women. And they put this down to like medication side effects and gait balance changes, but there hasn't really been much research about bipolar and falls. Osteoporosis. That sort of links in with falls because of the increased fracture risk if you've got osteoporosis. I'm also lead of the Liverpool Osteoporosis Support Group, which the Royal Osteoporosis Society does try and promote things, and the support groups are useful resources for patients and things. And I think there probably is more links between osteoporosis and mental health issues, but I just don't think that research is quite there, because like depression and osteoporosis, they are linked, and possibly due to like both of them have low vitamin D, both of them you've got increased parathyroid hormones, and you've got sort of like medication side effects and reduced activity. I mean, there isn't a genetic causal relationship between depression and osteoporosis, but both depression and osteoporosis are not just genetic conditions. Both of them, yes, there's a genetic element, but both of them, it's the environment as well. So I think there is more of a relationship. And bipolar and schizophrenia are independent risk factors for low bone density. I mean, the thing with osteoporosis and fractures is that majority of people who fracture actually have osteopenia, which is the bone density of T-score -1 to -2.5, and osteoporosis is T-score of -2.5. T-score being comparison to someone of your gender, 20-something-year-old of your gender's bone density compared to you. But yeah, more people have osteopenia than osteoporosis. And also, although osteoporosis is diagnosed as the -2.5 T-score, there is a lot more to bone than that. It's the bone quality as well. And there is a growing awareness that the bone quality, the angle of your femur and things like that are a factor with fractures and osteoporosis. It's not just the T-score. And so I think that's, you know, like the increased fracture risk as well. It's not just how dense is the bone, it's the quality of it as well. There is some research into bone health and bipolar, but not much. I mean, lithium might even reduce risk of osteoporosis. With the schizophrenia, they think it might be the hormone issues, so such as lower follicle stimulating hormone levels and other hormone things as well might be a factor. And also with dementia, osteoporosis increases risk of dementia. So I'm doing a professional doctorate, which is like a PhD, but the thesis has to be clinically relevant. So I know probably some PhDs theses are clinically relevant anyway, but the professional doctorate, it has to be. And also the thesis is shorter. Yay! It's more work-based compared to the research-based PhD, but with both of them, you get to be a doctor at the end. So yeah, so my previous research, so that was part of my postgraduate taught section, so that was like equivalent of a master's that I did. That was a qualitative study to understand falls interventions used by mental health physiotherapists for people with affective disorders. Not give up. And I did a focus group virtually with 4 physios who worked in mental health. They all happen to be inpatient physios, I think, because that tends to be where a lot of mental health physios work, more in inpatient. I mean, I'm community, but I think the majority are inpatient. Use thematic analysis to find the 4 themes. So falls assessment pathway. So the 4 physios were all from different hospitals, and each hospital did have like a falls assessment pathway. But there isn't like a national standardized one, but they had all used like NICE guidance and things to generate the falls assessment pathway. So they were all sort of similar. Motivation and capacity. So that was both for staff and patients. So sort of like whether the staff were motivated to be engaged in falls management or not, and sort of falls stuff. And also the patients. So that was more, the patient's motivation was more linked in with like the mood and whether they're depressed or manic. And the capacity was sort of like how falls interventions tend to be focused on the older people's wards, because they are more likely to fall on the older people's wards. but there is, compared to the general population, there is increased falls risk on working age mental health wards. And the working age mental health wards, when they do get a fall, tend not to know how to cope with it as well as the older adults wards. Everyone's a complex individual, so the risk factors for everyone with falls are different. And as I'll mention later, falls is a wicked problem. It's complex. There's many different reasons why you can fall. And so it's sort of being aware of that with managing the assessment and the management process. And the physical activity and keeping active. So the importance of we as physios promoting that physical activity and trying to maintain it from the ward into the community setting. Right. So I'm now in my postgraduate research stage, which is part-time and can be up to 8 years. And at this rate, it will be 8 years. But yeah, I'm co-developing falls guidance for staff who work with inpatients with mood disorders using the double diamond design approach. Very much a work in progress, and I'm slowly getting there with ethics. I have got some of it, but yeah, it's working. So I'm doing co-development with patients and staff. So I'm hopefully going to use 3 wards in one NHS trust. So they're wards that I don't work on to prevent power imbalance. And I'm first of all going to do some staff focus groups. So I'm going to do 4 virtual focus groups with 3 to 8 participants. And there'll be 2 separate working age focus groups. So one for the male working age adult ward and one for the female working age adult ward, and then 2 older adult focus groups. Just because, like I said, I think there are different issues with the working age and the older adult for the falls risk factors. And so I want to sort of find out what they are. And the working age, they have fewer falls, but they tend to not cope as well when they do have the fallers. And it's sort of finding out what they want. And the older adults wards are often better at coping because it happens more frequently. And I want to get a range of professions in the focus group. So like the medics, nurses, therapists, psychologists, and assistants, just to get a range of views. And then at some point, I'm going to do some patient interviews. So I want to do between 9 and 16 face-to-face interviews. So it'll be with voluntary patients because just the issue with if they're sections, the whole whether they think that taking part in the research will help them get off their section. So that's why we're going to do it with voluntary patients, informal ones rather than sectioned. And it just helps with the consent if they're voluntary. And it'll be working age and older adults patients that I interview. And they have to have a mood disorder and fallen at least once in the previous 12 months. It doesn't have to have been on the ward. It can have been at home before they're admitted. And the fallen at least once in previous 12 months is the best simple question to work out falls risk. Just have they fallen in those 12 months? I mean, I've fallen in the last 12 months, so yeah, affects my falls risk. But it's a good simple question, and I don't want to go down any of the falls risk factor tools because A, NICE is not majorly keen on that sort of thing, and B, I think it just gets more awkward if someone's like low, medium or high. So I'm just doing if they've fallen at least once in the previous 12 months. Because of course there is existing falls guidance like NICE, which released their updated guidance last year, and they do mention that cognition and mood should be assessed, and they do also say medication review for those taking psychotropics. And the World Falls Guidelines by Mondero Dassa et al. In 2022, they mentioned depressive symptoms, about how you should include that in your multifactorial assessment, and refer on for specialist input if needed. But that's actually only expert advice. It's not, there aren't enough quality studies yet for them to sort of give definitive guidance. I mean, they do also mention sort of like about impulsiveness and agitation should be, assessed, which you could say that sort of like could be with manicness or depression, but it's very much just expert advice at the moment. There's no specific guidance on how to adapt it for mood disorders. So I'm using the double diamond design approach because double diamond works wonders with wicked problems like falls. Because falls, there are many different reasons why you can fall. That's why they struggle to have like a single assessment tool that covers everything, because there can't be. And so design thinking is good to manage like the wicked problem of falls because it's an iterative approach and it's human centric. And yeah, it is the framework and methodology that I'm using for my professional doctorate. I did not realize how much philosophy would be in a professional doctorate, and so the double diamond is my philosophical approach. And it has been used in falls research by Block et al., and it has also been used in dementia research. Yeah. So I've got the 4 stages of the double diamond. Discover, so that's the divergent thinking, and that's with like the staff focus groups and the patient interviews. Then got define, where I'm going to use the experiential reflexive thematic analysis with convergent thinking to come up with the themes from the focus groups and the interviews. And then I'm divergent thinking again with the develop stage to develop the falls guidance. And one of the questions in the staff focus group is about what sort of guidance that staff want, how do they want it presenting and stuff. And then I'm going to present it in the journal at meetings like this, training sessions like this and conferences and things. So yes, share the guidance. I'm using experiential reflexive thematic analysis. I'm sure if any of you know thematic analysis, you know and love Braun and Clark using their technique. So it's experiential because I want the staff and patient voice to be heard. So I want to know what they think and about falls and falls management. And just because, like I said, this is a co-development thing, so I want to hear what they think. And falls guidances aren't always clinically implemented and things, so how can we get them clinically implemented? It's reflexive because I'm taking into account my own views and biases, because I have done a practice focus group, and I was aware when I was doing that I wanted to talk about my own experiences and things, but as the facilitator, that's not my role. And so it is that this is qualitative research, and it's being aware of I'm not a blank slate. I have got my own views and experiences, and I think that's why I prefer qualitative now to quantitative, because I think qual takes that into account, your you-ness. So yeah, so it's reflexive. It's inductive because it's data driven. I am not starting with a theory, and yeah, it is the data that I get from the staff and the patients will help me work out what I'm doing. And semantic because I'm doing the explicit meanings. I am not digging into hidden meanings. Yeah, spade's a spade. So yeah, I've got the 6 stages of the familiarization with the data. So I'll sort of read the transcripts, re-listen to the transcripts, get to know the transcripts, then generate some initial codes. So it's like some theme, and then just search for themes so that link the codes together, and then reviewing themes to see if I think that they make sense, to think that they've got like one core idea, but that they link to each other like a story. And then it's defining and naming the theme. So I might use like quotes and things to work out exactly what they are, and then producing the reports. Ethics, yeah, this is the long bit. I have got the University of Derby Health and Humanities ethical approval, but HRA IRAS just seems to be long, and I'm hopefully submitting that soon, but it's just long. I can kind of see why there isn't much research done based on ethics, but I don't want that to put people off, because I think ethics committees, because I'm actually on the Derby University Health and Humanities ethics committee, and they are just people who want to make sure the research is as good and safe as it's possible to be. So I don't think ethics should be viewed as this big scary thing, because they are trying to make things good and safe. It just seems long. But yeah. And any questions? I've whizzed through it for you for the football. These are my references.
I don't think we've got any questions in the chat as yet. We'll give a few moments for people to take that in. I can remember
Oh, good, I get claps. Yay.
I can remember back being a student physio, working in mental health, and we had a patient who was a long distance lorry driver,
Oh.
and he'd had a fall and fractured his hip, and his rehab was quite long time. Yeah, because you were saying about the motivation and the wanting to get up and get going, but very, very important work you're doing.
Yeah.
Okay, we've got a question here from Marissa Herbert. It's all jumping up. Do you recommend any exercises to help growth?
What was that? Brent falls in this group. I think one thing that gets me with like the falls research is that it talks about how you need to progress the exercises. In my experience, just getting some of our patients just to like move is good. And so I think the recommended particular exercises, it's what the patient is willing to do. Balance exercises are always good with like the planning, so like the stepping and things, so that the body knows how to react if they have had a fall, sort of thing. So if you do like the lunges and the side steps, it's like getting the body prepared for, if I fall, I'll do this. But I think often with the mental health patients, it's getting them to do something. And yeah, so that's what I'd recommend. Yeah. What other questions?
I think Rianne's got her hand up. Hi, Rianne, we miss you.
Hi everyone, miss you all. Good to see all of you. Vicky, thank you so much for that. That was a really interesting, wonderful talk. Super close to my research as well, so I apologize in advance if I start rambling. But the first thing I'll say is good luck with ethics. I am also in that process. I've got one. doing the other one now. I feel your pain. 6 months in, you'll get there eventually, but it is a long slog. So my PhD research, I looked at depression and hip fractures and
right.
the role of rehabilitation. And I kind of pre-PhD kind of had this idea that I was going to be looking at those who had a diagnosed mood disorder. And kind of that would be where my focus was. As I got through the PhD, I realized actually there wasn't so much there. And the conclusion at the end of my PhD was that people who do actually have a diagnosed mood disorder, they didn't have that much of a difference in terms of their physio access, their outcomes, compared to, say, the hip fracture patients who didn't have any mood disorders. There was actually no difference. So I shifted my work into looking at those who were sub-threshold of a clinical diagnosis. Yeah. But the work I'm kind of doing now is I'm starting to overlap more with generally looking at, I guess, mood disorders, but also looking at other psychosocial things that come into and impact our patients. And again, my focus is completely older adults, so I'm in the kind of fragility fracture population, but also looking at fear of falling. And I've got some colleagues who are doing work on fear of falling. So I guess my rambling questions is the consideration for falls as the entity of someone falling over, but what about, or do you have that consideration of the psychological impact and what comes with the fear of falling as well for, I guess, older adults, but generally in the population that you're looking at?
I suppose the depressed ones are more likely to have a fear of falling. And you can get that with like the depression of perhaps they are depressed because of a fall, or perhaps they're worried about falling and that's making them depressed. So I think with that side, yes, and just I think the depression's just sort of stopping them in so many ways, and then just sort of like the fear of falling just sort of added into that mix. And I think the manic ones, they don't have a fear of falling. And I find them quite fun because they've not got that fear. And I think I think fear of falling is an important question
Mm.
because I don't think it's as straightforward as people think it is. And I think, yes, you've got people who are depressed, who have terrified of falling, but you also get people, I think particularly like you can get some Parkinson's patients who fall loads. And they're kind of not that bothered because they're kind of just stoic about it. If I fall, I fall. And yeah, and I think you do have, because I know sometimes with the falls work I'm doing, people will sort of say, well, of course that patient's going to be afraid of falling. I'm like, well, no, we need to ask because they might actually not be. And I think we do falls efficacy scales. We tend to do the short one, but sometimes do the longer international one. And I think it's useful asking those questions. Some patients just get more flummoxed by you asking it, so I just stop talking. But other patients, there is a benefit sometimes from going into that detail about, well, where exactly are you afraid of falling? And I think it does vary patient to patient. But yeah, I think it is a complex issue.
Yeah, definitely. Exactly like you said. And I think the other thing that through doing my work, I kind of initially was looking very much in my my narrow focus of just looking at depression, but actually there is the need to consider fear of falling, anxiety, and the interaction between all of those and how they could potentially be present in in one person, and how you then manage that.
Yeah, it'd be interesting to have a look at your research.
Yeah, I'm happy to send you my stuff.
Cool. Yeah, thanks. Yeah. Shall I just look at the chat for questions? Because like someone was asking about learning disabilities. Yeah.
Sure, Vicky, if you're happy to go down and have a look, that's absolutely fine. Perfect.
I don't know any statistics specifically with people with learning disabilities because I'm not really looking into that. I'm more focused just on the mental health. But I know learning disabilities, they are at increased risk of falls. And I know there has been some research both in the UK and internationally about falls and learning disabilities. The population that I'm focusing on is very much the inpatient mood disorders, just because that is a more manageable population for my professional doctorate of sort of like people who've got a diagnosed mood disorder are an inpatient. Because initially I was wondering about the community, but like one of my supervisors said that would just be too broad, and there is a definite risk factor for inpatients on mental health units. And I think the thing with the mental health staff, the nurses in particular, they are very mental health, and so sort of the falls can scare them sometimes. So I think that probably your physical health nurse would cope in a different way, and so that's kind of why I think there is a need for this research for the inpatient staff, because I think sometimes they don't cope as well as the physical health ones. The work-based PhD is professional doctorate. I am doing it through the University of Derby in health and social care, but professional doctorates, if you just Google, I think quite a few of the universities do professional doctorates now. And after I did my master's, someone suggested professional doctorate and I hadn't heard of it before. And then when I looked into it, I was like, oh yeah, that would suit me a lot better than the PhD. So that's why I went down the professional doctorate line. I am self-funding, which is not the cheapest option, but at least that gives me pure freedom to do what I want. Yeah. Is there any other questions? How did you manage your ataxia patient with baby falls? We had him on a one-to-one and we tried to get him to sit down. And I think we had him on a one-to-one, made sure he had suitable footwear. Walking aids weren't really suitable because so it was more that sort of trying to calm him down and trying to sort of remind him that he needed staff support and, he could use his wheelchair. Are there any communication strategies that you recommend to adhere to therapy as much as possible? I think just trying to what patients like and just trying to encourage them and things, and just do what you can. Akil, what are main barriers or adaptations required when applying exercise to patients with complex mental health needs or mood disorders? I think like that's partly why I'm doing the research, to find out more about that. But I think just like their motivation and just them not being that bothered about it, and sort of trying to motivate them, and just that trying to have them focused on the physical, being active, helping their balance and things. Yeah. Have you had any luck in getting action in working age adults? I think the getting physio care plans with the working age adults, I think I work closely with my OT colleagues who are based on the ward, and it's sort of like working with them and things. It's, yeah, I'm mainly older people's and just visit the working age wards, which I do like as a change. But yeah, they are very different settings, and I think it is that therapy focus that we have to try and do to sort of remind the medics that it's not just meds. And some of the patients themselves are actually very focused on the medication, and it's trying to point out to those patients that there are other options. How can we better link Fool's assessment with mood assessment? Well, yeah, because I mean, nice guidance. We are supposed to be checking about mood and things. I suppose it depends on the patient. And I mean, I suppose perhaps we should be asking patients how they are and things. Yeah. Is the HAD? I don't really use that much, the HAD. I'm sort of still in the sort of planning stage of this research. Seems to be going on for a long time. But I think I'll see once I get onto the wards about that. In my experience, it's more because they've got to that stage of being an inpatient. Well, we know they've got the mood disorder, and so that's kind of like the stage I'm working with if they've definitely got depression. Yes. Okay. I think, is that it?
I think there was one more question, Vicky. Let me find it. It was just a bit further up. What are the main barriers or adaptations required when applying exercises to patients with complex mental health needs or mood disorders?
I think like the motivation and trying to encourage them, and it is what they're willing to do, and it is sort of like work with the patient for what they're happy to do, and sort of like what they used to do, what they're willing to do. Groups can be useful, because like I had one patient who really wasn't into exercise. He was a lifelong academic in classics, but actually he got to an exercise group and he quite enjoyed the interaction with other people. And so I think it's what people like doing, but also, you know, trying groups and things. Yeah. Is that any other questions?
Brilliant, thank you. Heather, do correct me if I'm wrong, but I think the presentation and the recording goes out for people that have signed up. Is that right? Yes, Beth is nodding her head. Go on.
Yeah.
Yeah, lovely. So everyone will get the presentation and with the links and the recording once we finish. I think it's important to say that following this, there will be a survey going out to everyone. So we'd be really, really keen to hear, you know, how you felt about tonight. And also there's some extra questions on there, just looking for your insight into kind of future learning and what you want to know and other bits. So we'd be really, really interested to hear from you guys. Are there any other further questions for anyone tonight? Lovely. Okay, brilliant. Well, thank you very much, Vicky. We really, really appreciate you coming to speak to us tonight. And hopefully you'll come and speak when you've finished.
Yes, I will.
Tell us all about your excellent work.
Yes.
Because I think everyone's be really, really kind of keen to hear about about that. And I suppose, Vicky, are you happy for people to maybe reach out to learn a bit more about the professional doctorate if they
Yeah,
have any
that's fine.
questions
That's
and
fine.
things
Yeah.
like that?
Yeah.
Wonderful. All right. Well, thank you everybody for joining us. Really, really appreciate it. And I hope everyone has a good evening, whatever that may bring. And yeah, keep up with the good work. Thank you.
Thanks.
Thank you, everyone. That was super good. Good to see you all as well.
Nice to